Today, I'm very pleased to introduce Jackie Timmons. She is a pediatric hospitalist at Children's Nebraska and the director of the Complex Care Clinic at Children's. And she's going to be talking to us today about cerebral palsy. So go ahead and take it away, Jackie. Thanks.
Hi, thank you all for inviting me. I was going to introduce myself, but that's basically me. So I have been a pediatric hospitalist for the past 12 years, and I just took over the Complex Care Clinic at Children's Nebraska about 4 years ago when Dr. Gary Lerner retired. And I know he was very well known in the Omaha community as a pediatrician. He started that clinic about 30 years ago. So I was very excited and stepping into big shoes to take that over. Our clinic is a multidisciplinary clinic that cares for children with a wide variety of primarily neurologic disorders. And so cerebral palsy is a very common diagnosis in our clinic, but we also see kids with spina bifida and a variety of other primarily neurologic conditions. They're able to come to our clinic, not as their primary medical home, but is a place to see multiple of their specialists in one setting, as well as therapists, dietitians, psychologists, social workers. So it's fairly comprehensive care, but they all have their own pediatricians as well out in their communities. We also see kids really from wide range all throughout Nebraska, and lots of kids from Iowa and some from Kansas. So it's a pretty wide scope that we have. And so that's how I ended up coming here to talk to you guys today, and I'm happy to be here. My kids go to Montclair in Millard, and I haven't seen that one pop up, but if the Millard Montclair nurse is here, hello, thank you for taking care of my kids from time to time. And I will share my screen and get started. Is that working okay?
Mm-hmm.
Okay. I have no disclosures to announce. So cerebral palsy is a two-part term that's pretty self-explanatory. It is a condition that starts in the brain and refers to an injury that results in a disorder of movement. It's a really wide-ranging condition, and children with cerebral palsy have a huge range of competencies and of associated comorbidities. And so it is the most common motor disorder of childhood. And the official definition of it is that it's a group of permanent disorders of development of movement and posture due to non-progressive disturbances in the fetal or infant brain. And so to officially fit the diagnosis of cerebral palsy, the cause of your disability is something that is non-progressive and permanent. And so having said that, that doesn't necessarily mean that the child's disabilities or their associated conditions don't evolve over time. They do, but the actual insult to the brain does not evolve over time or change or worsen in any way. And so that's our official definition. We're going to talk about a lot of associated comorbidities and a lot of things that you might see in children with other genetic conditions or other neurologic abnormalities. And so I think there's a lot of overlap in what we're going to talk about and what we're going to, what I hope that you can take away with it from this. But to have this official diagnosis of CP, this is kind of what you have to have. And so as we said, this is due to an insult in either the fetal or the infant brain. And so the timing of this can happen at various points. Prenatally, we see certain prenatal infections in the mother that can lead to CP, intrauterine stroke. This is where we would put the category of congenital or genetic anomalies that we're now realizing with better genetic testing are more and more a cause of CP. We used to think that perinatal events, specifically birth asphyxia or birth injury, were much higher, cause much more CP than we have now really learned that they are. We now say that only about less than 10% of CP is really caused by birth injury or birth asphyxia. And then of course there's postnatal events. And so unfortunately, you know, in the neonatal period, babies' brains are at higher risk of infections and bleeds due to prematurity, things like that. And so all of those conditions can lead to CP. We do see some young infants that unfortunately suffer non-accidental trauma or hypoxic ischemic brain injury from near SIDS events or other things in that category that can also lead to CP. And then we see a lot of similar outcomes and similar comorbidities in older children who have a traumatic brain injury or have meningitis. And while they don't always then get the diagnosis of CP because their injury occurred later in life, the eventual outcome looks very similar. So there's a few different types of cerebral palsy as far as what parts of the body are affected. So again, this always originates in the brain, but it's a motor disorder. And so this is how kids are classified when it comes to just an easy way to describe what part of their body is affected. And so monoplegia with just one limb is pretty rare. Hemiplegia, so one side of the body, we see more commonly in strokes, either prenatal strokes or postnatal in the infant period. Diplegia, it means the legs only are involved, and then quadriplegic are obviously the most severe cases where all four limbs are involved. We have a scoring system or a classification level that we can use so that we all are speaking the same language when we're talking about a child's abilities with CP. And this is called the Gross Motor Function Classification Scale, so GMFCS. And we typically don't rely much on this system before the age of 2. And in most cases, pediatricians and neurologists don't really give a diagnosis of CP before about age 2 to 3. But after age 2, what a child is able to do and where they fall on this classification scale is really very predictive of what they'll be able to do for the rest of their life. And so just as an example, children who can sit independently and pull to stand by 24 months have a very high probability of being able to walk independently in their life. About 75% will be able to walk independently if they've achieved those 2 skills by age 2. If by age 2, children are not able to do those things independently, then it's really unlikely, but of course we never say never, but unlikely that a child will be able to walk independently. We use this a lot in the therapy world and in the orthopedic world and the neurology world to really discuss what a child can do and then to have a little bit of an idea of their prognosis. And of course, some of their prognosis certainly depends on their associated comorbidities and the underlying etiology of how they have this diagnosis of CP, but it's just a really good way for us to all be on the same page. So you can see there's a huge range when you get to see a child with a diagnosis of CP on paper. Unless you can see this level 1 through 5, it's really hard to know what kind of child you're going to actually walk in the room to see. So as I've already kind of mentioned, we talk about cerebral palsy being a disorder of movement, but I thought this was a little bit sort of an interesting and maybe even a little misleading graphic that I wanted to include, because this, shows that there's damage to the brain leading to this alteration of movement or loss of muscle control. And while that's true, and that's the primary outcome that we see in CP, it is very, very, very likely that the child with CP may also have abnormalities in their thoughts or intellectual capabilities or processing, and in the way that some of their vital organs work. So that's what we're going to talk more about in a minute here.
You're welcome. Love you, bye. Have a good night.
There are, this is just a small sampling of associated conditions that go along with CP. And we're going to talk more in depth in a few slides here about some of the medical reasons that a child may end up in a school nurse's office with CP. But I wanted to just point out a couple of the things on this chart that are probably not going to be the primary reason they're going to come to a school nurse office, but are going to be things that you would want to keep in mind when communicating with and dealing with a child with CP who maybe comes in for a respiratory issue or a fever or something else. So a high number of the children with CP have intellectual disability to some degree. And so of course this is going to affect all of their school experience, but their means of communicating and explaining to you what might be going on and how you're going to interact with them. There's likely to be some sort of intellectual disability. As we saw on that classification scale, many are non-ambulatory. Many are nonverbal, which doesn't necessarily mean that they cannot communicate in some way, but they may not communicate verbally with you. A high number have some sort of visual disturbance or visual impairment. 1 in 10 are actually classified as have cortical vision blindness, but many have glasses or some other lower form of impairment. And then not a high number, but certainly higher than the general community have hearing impairment as well. So kids with CP come with a lot of equipment, and I think it's helpful to just be aware of the equipment, even if it's not necessarily something that they're coming into the office with, but to be aware that they interact with this equipment throughout their day and to know how it's used, I think is super helpful and just makes people a little bit more comfortable when meeting a kid with CP. We're all familiar with, standardized wheelchairs. This is a manually powered wheelchair. So of course, this is going to be for a child who has pretty good use of their upper extremities to get themselves around. Wheelchairs come in a huge variety of technological capabilities. So this is a super high-tech wheelchair with all sorts of bells and whistles. These often have trays attached to them or arms attached to them for a speech device, things like that. Oftentimes, almost universally, kids who are in this kind of wheelchair are going to be strapped in with various restraints because their posture is not good enough for them to maintain a sitting position in the wheelchair. Some of the higher functioning children will use walkers like this. And then in our children who cannot walk independently or cannot even walk with a walker, weight bearing is so important for their orthopedic health that they will oftentimes be using a stander either in school or at home. And so a stander just provides them total support so that they, are safe in this position, but also provide some weight bearing onto their lower extremities. Most children with CP, once they outgrow the standard car seat, will be fitted for an adaptive car seat. They may not have the trunk support to be able to sit with just a booster seat or a lap belt. And so we'll get them fitted for a seat that looks basically just like a larger version of an infant seat. And then in the classroom or even at home, there's other seating options for kids who may not be in a wheelchair all day long. We can put them in other chairs. This is a really common one that we hear and you may see around schools, called a tomato chair, but it just provides nice cushioned supportive seating with a workspace for them. Kids with CP may come in with different kind of bracing. So these are AFOs. These provide stabilization of the foot and ankle and fit nicely inside shoes. So many of the children with CP who are ambulatory will wear these. We also fit kids even who just use standers so that their feet can really be in that nice, L-shaped position when they're in the stander. SMOs are sort of just a shorter version of this. These are made of plastic. And so this will be important in a little while when we talk about pressure injuries, but all of these things can rub and can irritate a child, especially in a nonverbal child, keeping in mind that a source of pain or discomfort may be from all of this equipment and bracing that they use. Many kids who have upper extremity insults have splints that they wear. Most times these are at night at home. A lot of times you won't see these necessarily in the daytime during a school day, but some kids who have really terrible, contractures of their hands, or kids whose hands are chronically in a fisting position. Their nails tend to dig into their palms and things like that. And so we can fit them for these braces that help keep their hands in a more extended position and try to prevent some of those more chronic contractures and things of their joints and muscles. And then a TLSO brace is probably less common to see, certainly than AFOs and SMOs, but may be used for children with scoliosis prior to where it's bad enough for surgery. This helps them with posture and respiratory issues that may come if their spine is curving and compressing their lungs a little bit. But you can see this obviously has the ability to cause some rubbing and irritation under those armpits. As we talked about, nonverbal children are, common in children with CP. And so there's a wide variety that you might see in the school setting of communication devices. So this is like the lowest tech version of just a picture book. This is a slightly higher tech where these little cards can be swapped in and out. And I think this is one that they can push a button and it will say the word that's on their card. Many of the children who come to my clinic have something like this, which is, fairly high tech. It's like an iPad and it's loaded with this alternative speech program that allows them to communicate, and many of them do it really effectively. Because this is a motor condition, it's difficult for some children with CP to have their brains connect to their mouth and their respiratory system in a way to form intelligible words, but this allows them to, really speak and let all their needs be known. And then this is, of course, on the highest end of the speech devices. This is an eye gaze device, which doesn't require any motor capabilities really other than eye movement. And so these are super high tech and amazing to see in use, where with a lot of work with a speech therapist, the kids can actually just look at what they want to say and it will speak for them. We don't see these super often, but the kids who do have them are very lucky and are really able to speak with high level complexities because of this device. I just wanted to share these only because this isn't probably going to be something that is ever needed to be brought to a nursing office necessarily, but it's just nice to know that these things do exist for CP kids. The occupational therapists have such a huge variety of little options of devices and adaptive tools that we can offer for kids with CP, these curved utensils, so that if they don't have that motion of their wrist, but they can still use an upper extremity to bring a spoonful of something to their mouth, they don't need to get it all the way. That spoon does that little extra last little bit to get to their mouth. If their grips are not strong, we can use these little holders on toothbrushes and utensils. And then down at the bottom here, we see a writing device for a child, again, with difficulty with grip strength or with that fine motor capability. So now I would like to just move on to the actual comorbidities that will often bring a child with CP into the nurse's office at school or cause some sort of potential medical emergency at school, which obviously these children are at higher risk for. So I included spasticity in here as just the first topic to talk about, even though I'm not sure that this is really considered a comorbidity. It's really just a hallmark of CP. So hypertonic or spastic CP is the most common type of CP that we see, and that you'll see. A small number of children with CP are actually globally hypotonic, and so they're floppy, they have low muscle tone. But this is going to be probably a pretty small percentage of the kids that you'll see. Oftentimes babies who will go on to have CP later in life are found to be floppy babies or hypotonic babies. But the spasticity then comes a little bit later in life in those kind of younger toddler to early school age years. And so Ultimately, many children with CP may have still low tone in their trunk, but their extremities become stiff with high muscle tone, muscle spasms, difficulty moving. Spasticity has various forms of treatment, and therapy and those bracing options that we saw a few slides ago are certainly part of the treatment, but many children with CP will be on a medication for spasticity. And many of these medications are not super long lasting. And so they're given oftentimes 2 or 3 times a day. And so it's certainly possible that a child would need to take a dose of their anti-spasticity medication in the middle of the day, in the middle of the school day. They're kind of in 2 different groups. And so baclofen or diazepam are 2 of the most common ones that you'll see. I should have included on here. I actually kind of just overlooked tizanidine. That's another spasticity medication that we use pretty regularly. Artane is a little bit of a different class that's more used for dystonia or those unintentional sort of uncontrollable movements that some children with CP have, but it also has an effect on spasticity. And then many of the kids in our clinic actually also receive Botox injections. Botox into the muscle can cause a lasting, typically 3 to 6 months worth of muscle relaxation that allows for just more use of that extremity. Botox is often used in kids who have had a stroke as the cause of their CP because it's a local, if you have just 1 or 2 limbs involved and you don't want that overall decrease in muscle tone that the baclofen or diazepam will give you, you could do just a localized injection into a particularly problematic muscle. Side effects of these is that they tend to make kids sleepy. And so this may certainly affect their school day if they are on, doses that are higher than what they're able to tolerate. And so we certainly have to titrate these medications pretty often to make sure that they're getting the decrease in tone that they need, but maintaining their level of alertness, and then also not making them too floppy so that they don't lose any of the skills that they have. A child who is ambulatory, we don't want them to lose too much muscle tone in their legs because of course, then they're not going to be able to stand and walk and make gains in therapy. Probably the most, or maybe the second most common comorbidity that we see in CP is seizures. This is a picture of a child undergoing an EEG, which our kids come in for, not super often, but regularly enough. We often admit kids to the hospital for 24 to 48 hour periods to capture what's going on with their seizures and see if we need to make adjustments of their seizure medications. You'll find a very wide variety of seizure medications that are used for children with seizures. This is not comprehensive, but I would say most of the very common ones that children, at least in our area of the world here in Nebraska with our children's neurologists, these are the medications that they like to use. Some of these are dosed 3 times a day. So again, it's certainly possible that children may need a dose of these medications during the school day. It would take up an entire lecture and more to discuss each of these and the side effects of them and how they all work. But I think it's a good idea to kind of have in mind that there's a huge variety and they have a wide range of how they're dosed. 1 a day to 3 times a day is the most common here. The more common thing that I think is important to be super familiar with are the rescue medications. So the previous slide were our daily maintenance medications to try to prevent seizures, but breakthrough seizures are unfortunately common in some children. And so there's various ways to break a prolonged seizure. And all of our children at Children's Nebraska who have seizures and are cared for by our neurologists there come away from their visits with a seizure action plan that is typically shared with the school. So I assume, you're probably all very familiar with seeing those. And usually that seizure action plan is going to have what are what is their next step for a seizure? So some seizures are short, and of course others can be very prolonged. And so there's usually a time limit, 3 minutes or 5 minutes, of when we would want a rescue medication to be given. There's various means of giving these rescue medications. Diastat is given rectally, and that used to be the most common. I think that was when I first got out of residency. That was essentially all the children with seizures, for whatever etiology of their seizures, would be prescribed Diastat, which is effective, but not the easiest to give a rectal medication in the middle of the school day in a larger child, certainly who's seizing. And so we have luckily gotten a lot better with how we can break these seizures using less invasive medications. So Valtoco is a really common medication that's intranasal diazepam. It's a little spray bottle. It looks kind of like Flonase. And then we, not so often here, but in other parts of the country, I used to practice in Phoenix, and the oral dissolving tablets of clonazepam were very popular. So even in a seizing child, you can usually slip a small pill in their cheek and get some seizure relief from that. Very rarely we have children who have some sort of oral medication or medication given through a G-tube to break a seizure, but that's pretty rare. Those take a long time to actually work if you're expecting something to be absorbed from the GI tract, and you don't necessarily want to add anything into their stomach while they're in the middle of seizing. So these are probably going to be your most common rescue medications. Some children, certainly not quite as many, but some children will have vagal nerve stimulators that also help with seizure control. This is a little device that's implanted on the left side of a child's chest over here with a little wire that runs up to the vagal nerve. What's interesting about these is that these actually provide a sort of constant on and off pulse of electricity to the vagal nerve, which over time can actually reduce the frequency of seizures, but then they also have the power to deliver a more, sort of powerful and sustained stimulation by the use of this wand. And so the wand is sent home with a family, and parents are instructed when to use it, at what point of a seizure would you swipe the VNS, causing a kind of a burst of that stimulation to the vagal nerve. And so children with a vagal nerve stimulator should have that included in their seizure action plan that's provided to, parents and to schools. Constipation, common in all children, especially young children with maybe not the greatest diets, not the greatest water intake, but certainly more common in children with CP. We see constipation primarily due to just their overall low tone, and which alters the motility of their GI tract. We may also see it because of their diet. Some children with CP who have other sort of associated behavioral or intellectual disabilities may eat by mouth, but may have restricted diets due to oral aversion or various things. And so they may not have the greatest fiber intake or fluid intake. And so we deal with a lot of constipation. There are various ways to treat constipation. Some of these may end up being dosed during the school day, but probably not quite as commonly. These are usually, morning and night sort of meds, but Miralax and lactulose are going to be two of the most common. We call them osmotic stool softeners. They basically just bring extra water into the colon to soften up your poop. Senna is more of a pro-motility agent, so that actually affects the squeezing of the bowel and makes it easier especially for kids with CP who just don't have the same pathways that talk to the muscles of your arms and your legs, also talk to those muscles around the bowel that cause the squeezing, that nice coordinated squeezing pattern that allows us to all eat and poop regularly, may be disrupted in CP. And so Senna can help just stimulate that push. I used to have a colleague that I used to work with used to just like the phrase, the mush and the push as the two ways to treat constipation. And so Miralax and lactulose give you the mush part, and Senna can help with the push part. Docusate is on here because we'll see a lot of children on Docusate or Colace, although there's not great evidence that it actually does a whole lot. So probably not used as often, especially in kids with severe constipation, because it's not particularly potent. And then some of our kids use suppositories and enemas either on a regular basis or on an as needed basis. Again, probably not anything that is going to be, asked to be administered during a school day, but on the list of their overall medications, certainly. So just a wide variety of all the things you can buy. Most of these are over the counter and are pretty common in our office. Drooling or sialorrhea is really common, especially in some of those lower functioning, so the higher GMFCS children have a little bit more trouble controlling their secretions. We use various treatments for this. You may see children come in with the scopolamine patch. These are the same patches that people use for motion sickness or seasickness, goes behind the ear. And as a side effect of controlling motion sickness, it actually also dries up your secretions a little bit. These are nice for families if they work for the kid because they last typically for 3 days. So it doesn't really add a whole lot to the everyday medication administration that a lot of these children already have a lot of medications on their list. So this little patch is a little bit simpler. We use glycopyrrolate pretty often. This is a little bit, I find, more potent, but oral medication to dry up secretions. And then some providers will also use atropine drops. And so it's actually the eye drop, but it's under the tongue. That just works in a very localized way to dry up secretions. The risk of these, of course, is making kids' mouths too dry. And so we don't want them to have, really overly dry mouth. That's bad for dental health. It also is thought to have somewhat of an effect on your respiratory secretions as well. And so especially for our kids, which we're going to talk about, I think, in the next slide here, many of them already have difficulty clearing mucus from their airways. And so we certainly have to be cautious about making that mucus too thick, that it's hard for them to cough up. And so these are also sort of a fine balance that we titrate up and down over the course of a child's life, depending on how much the drooling really bothers them. Sometimes we treat this solely because it's causing distress with families and schools having to, change bibs or change shirts many times a day. Sometimes it causes that, wetness, chronic wetness and irritation on a kid's chin or neck that becomes problematic. But sometimes we treat this really because a child can't handle their secretions and is actually aspirating. And so if the drool is not coming out the front of their mouth, it's going back into the airway and causing, chronic cough and choking. And so there's a wide variety of reasons why we might treat drooling problem. Many children with CP, again, because of the muscle coordination issues, may have difficulty coordinating swallowing. And so we are regularly evaluating children with CP for signs of dysphagia. In some children, it's obvious and severe right from the start. We know that they're not going to tolerate food or drink by mouth. And some children, we recognize it a little bit later. Unfortunately, it seems like things are going well, and then they have a series of respiratory illnesses or one serious aspiration or choking event. And then we need to make some changes in how they receive their nutrition. So I think probably relatively uncommonly in the school setting, we see a child with an NG. This is usually a short-term solution. This is more often in babies where they're just diagnosed as not being safe to take, formula or breast milk by mouth. And so we have a period of NG feeds before proceeding to a G tube. Occasionally we do use NG tubes in older children who have had some recent serious illness and they're just not yet ready to eat or drink. But I think it's probably less common that we get to the point of actually sending kids home and back to school with an NG tube, although it may be. And so these are a little bit problematic, of course, because they can come out. And we teach parents how to replace an NG if we do ever send kids home with them, but it's not necessarily a fun procedure or something that all parents become super comfortable with. And so it's, you know, certainly important to have a real good secure taping of the NG there onto the kid's skin to try to minimize how often that tube comes out. More oftenly, of course, children with CP undergo G-tube surgery. And sometimes, again, this is in the infancy period and it's just a part of their daily life from the beginning. And sometimes it happens a little bit later in life as their condition changes, or if it becomes clear that they're not able to keep up with their nutrition and their weight gain stalls. Oftentimes we may recommend a G-tube for supplemental feeds. So there are plenty of children who eat by mouth, but then get some supplemental calories through the G-tube, either at various points during the day or sometimes through overnight feeds. And then they just eat by mouth with the rest of their school and the rest of their classmates during the day. Feeding by tube, either NG or G-tube, can be done by a pump or just simply by gravity. And so there's various reasons why a child might need one or the other. Gravity is obviously the easiest. You just put the formula in a bag, hang it, and it runs in. You can change the rate a little bit by clamping that tube here and there, but you're kind of limited with, you have to be able to take all of your formula at once. And so sometimes children with more severe motility issues can't handle, 8 ounces of formula running in over 20 minutes. And so they end up with vomiting. And so we arrange for them to have a feeding pump, which can be set to whatever rate you want it to go at. So children who get overnight feeds typically have a feeding pump at home, and they get fed a few ounces an hour over the course of 6 to 8 hours while they sleep and get that supplemental nutrition that they might need that they're not getting in the day. We have various kinds of formulas that children take by tube. These can also be taken by mouth, and they have varying levels of good flavor, but more often these are used by G-tube or NG-tube for supplemental or complete nutrition. Nowadays, a lot of parents, ask and prefer for their kids to actually be on real food blended up. So we have a lot of families who, just don't really love the idea of their older child being fed formula. They think of that as an infant thing that they have gotten past, and they want their child to experience, real true blended foods. And so it's very difficult for us to really assess nutritional content and calories and things like that when families blend up their own meals and feed it. And so we do have some children whose families do that. They blend up all their meals, just whatever the family's eating that day. They blend it with some water, get it to a consistency that will go through the G-tube and feed it. But then there's a product like this that has actual real foods blended up. There's different meal types. And so there are breakfast ones of these that have oatmeal and other breakfast type foods, and then various kinds of lunch and dinner foods. The key with these is, while these kind of formulas are complete nutrition, you can drink Boost for every single meal all day long, and you will have all of the vitamins and minerals and nutrients that you need. Whereas these, because they come in different flavors and different meal types, we wouldn't want a child to have turkey, sweet potatoes, and peaches for every meal of their life, because they'd likely be missing out on certain vitamins and key components of nutrition. And so we have families mix it up. And then, of course, water. We have, we all need water. Lots of the blended foods have plenty of water in them, but most of our kids will have some supplemental water either after their formula or real food feedings, or separately during the day. Moving on to our last here, comorbidity. Pulmonary issues are the leading cause of hospitalization and death in CP patients. Many children with CP are born prematurely. And so while that premature birth has an effect on their brain, it also can have an effect on their lungs. Many of them, like we talked about a couple slides ago, have had chronic aspiration for some time before maybe it's become apparent, or maybe ongoing, even though they're fed by G-tube, they have reflux that then they're aspirating, causing chronic damage to the lungs. And then many also have that ineffective airway clearance. And so it's difficult because of their motor dysfunction for them to actually clear the secretions or the mucus that they might have, especially during times of illness. Only about 5% of kids with CP have trachs, but they're not that uncommon. And just because kids have a trach doesn't mean they're necessarily attached to oxygen or attached to a ventilator. There are children who have trachs because of upper airway abnormalities that would make them at risk for just breathing through their nose and their mouth. And so like this little girl here appears to not need any supplemental assistance during the day, but she may be on some humidity or some oxygen at night, depending on the situation. Kids with CP also have that low truncal tone, even though their limbs may have spasticity, their trunk tends to be low. And so sometimes that can also just mean a floppy airway. And so they may have a tracheostomy because of a floppy airway. Many of our kids have the need for either inhalers or nebulizer treatments on an as needed basis, which I'm sure with just typical asthma, everyone is really comfortable and accustomed to seeing these same kind of albuterol inhalers or nebulizers. Some of our kids with CP and chronic lung disease use these treatments on a scheduled basis and not just an as needed basis. And then a kind of higher level airway clearance assistance device that many of our more severe CP kids, but also kids with cystic fibrosis or other chronic lung diseases, will use something called a cough assist device. This is a mechanical device that looks essentially like this, or it can go through a trach that causes sort of a push of air into the lungs with a real quick suck back out. So mimicking a cough. Because of the motor dysfunction that occurs with CP, it's difficult for many of our kids to have an effective cough. They may have a weak cough, but that's not really moving anything around. And so some of our kids use cough assist every day, and some of our kids have cough assist device as their sick day plan. So the second those parents start realizing that kids are getting a runny nose or, any sort of respiratory symptoms, they start using the cough assist 3 or 4 times a day to try to prevent that accumulation of secretions and mucus that may end up leading to hospitalization or need for oxygen. And oftentimes with a cough assist, kids will use a percussion vest or some other kind of chest physiotherapy. And this essentially just rattles them around and shakes them up so that mucus is kind of loosened so that it can then either be coughed up or pulled up by this cough assist device. So I probably should have put these graphics in an opposite order because usually the vest is used first before the cough assist. I forgot one last comorbidity here, orthopedic, super common. Most common orthopedic thing that our CP patients will deal with is hip dysplasia and dislocation. This is something that children with CP are monitored for typically on a yearly basis with x-rays from the time of diagnosis of CP. And at a certain point, depending on how severe this ball or the head of the femur ends up out of the socket, many of our children will undergo surgery for hip dislocation at some point in their life. Scoliosis is really common. This is obviously a very severe scoliosis. And in this case, many of our children with CP or with other neurologic disorders will end up undergoing a spinal fusion where these rods and screws are placed in obviously a pretty big surgery, but can have a decent effect, positive effect on quality of life, pain, and also respiratory health. So you can see in the scoliosis picture on the left, these lungs are getting a little bit squished and may have difficulty handling, minor illnesses that can lead to pneumonia because they just can't clear and get enough air in there. And so we see a lot better expansion of the lungs on that right side after the spine was straightened. We see contractures. Unfortunately, these are going to be, typically in our older kids, this happens over time. This is muscle shortening that occurs near the joints. And so you can get contractures in any of your limbs or your back. And this is what we try hard to avoid with treating spasticity and with appropriate bracing and appropriate therapies. But once this occurs, it's very difficult to treat. This basically means that the joints are sort of stuck in this flexed position. And once you're at this point, this is really treated only with surgery. And of course, undergoing surgery in children with all these other comorbidities is always a risk. And so we have children who were able to stand in a stander early in their life, despite not being ambulatory. They can get up in a stander, they can get those feet into that, standing position and straighten their knees and do that important weight bearing. But later in life, unfortunately, develop contractures and so can no longer stand. Standing is, like I said, very important for bone health. And so the lack of standing or the lack of weight bearing in any way in our children with those level 4s and 5 CP leads to osteoporosis or decreased bone mineralization, which leads to fractures. So especially in a nonverbal child coming in with signs of pain, we always want to think about, is there a potential fracture somewhere that they can't tell us about? Kids with CP are often lifted and moved and put in various devices, the car seats and the tomato chairs and all the different things. And if they have that low bone density, they're at risk for fracture anytime they're moved. So we try to keep a close eye on this by monitoring their bone health. And we do various treatments, oftentimes infusions on the inpatient side of things to try to improve their bone health, especially for our kids who can't stand. So I wanted to just briefly talk about pain because I think pain is, not an uncommon reason why a child might seek medical care or be brought to a nurse's office if teachers or, other school staff believe that they're in pain, and especially in our nonverbal kids who can't describe where their pain is. Pain can come from all these things we talked about. So hip dysplasia is one of the most common causes of pain, but just the spasticity of that constant muscle contraction in itself, if that's poorly managed with medications, children can be in pain. They can have reflux, constipation. They have a higher rate of dental cavities and things like that, especially in our children who don't eat by mouth, actually increases the rate of cavities and other dental issues. And so if they can't tell us that it's their tooth abscess that's hurting, and sometimes those things are hard to see from the outside. So these are all, things we consider in that patient who has obvious signs of pain, but we can't figure out where it's coming from. And then finally, I wanted to just talk quickly about pressure injuries. Not really necessarily in depth. We don't need to talk about the different stages, although this is important once we see a kid with a pressure injury. I think it's just important to remember all those bracing and seating and various devices that kids with CP use on a daily basis can rub and irritate and end up causing these skin irritations that, if not addressed early, can really lead to serious infections. And so we want to always catch things early on. And so if we see a child where their wheelchair is rubbing on their hip or on their sacrum, or their TLSO brace is causing irritation under their arms, or their AFO is rubbing on their, ankle bone, that we address those things early. We like to use these foam gel dressings to really provide a cushion as a temporary measure on whatever part of the body is being irritated. These come in all sorts of shapes and sizes. This is like a sacral shape. Sacral ulcers are real common, especially in the wheelchair-bound children. But the most important thing, really, if we notice these things, is talk to the PT. The PT is in most cases going to be the person who's going to look at the device, look at the wheelchair or the stander or the brace, and figure out what part of this is rubbing and what modifications can we make to try to stop this from happening. And so this can certainly happen like first line at the school level. Many of our children will have a PT in school and also have an outpatient PT that they see, but some children, the only physical therapist they see is in school. And so this is, that's really our first line help in figuring out what is causing this irritation and how can we fix it before it gets to the point of these stage 2, 3, and 4 ulcers that are much, much, much harder to treat. as we have talked about, the CP team for most of our children is huge. This is I put these different medical providers as just a most common list of people who may be involved in a child with CP, but you could really list every medical specialty because there's just such a wide range of comorbidities. We talked about the most common ones, but it certainly wouldn't be unreasonable to think that a CP child may also see a cardiologist or a nephrologist or a urologist. Outside of all of these physician members of the team, we have the therapists. Many of these are in the schools, PTOT and speech. You know, like I said, many children will receive these therapies only in school. Some have additional therapy outside if they're lucky and their parents are able to, you know, accommodate that for them. But many times these therapists are only in the school setting. Typically, our kids have some dietitian that's following them. Many of them have a psychologist involved due to behavior issues, or in our higher functioning older adolescent CP patients, their you know, mental health and social issues become a little bit, you know, harder to deal with in some cases, and so many of them will end up seeking help from a psychologist or a therapist. Special education teachers, and then of course I should have highlighted it in bold, but school nurse. Everyone is part of the team, and I think the best way to give the best care to children with such a complex diagnosis like this is to have everyone recognize that they are part of this huge team. And so concerns that are seen in school, we are more than happy to help deal with, you know, in our complex care clinic or in the pediatrician office. We want to hear from all the members of the team, anyone with a concern, anyone with something to add about how to make this child's life better. We want everyone to be parts of this team. And then finally, I just wanted to do a real quick other couple little things to touch on. I know you're probably all much more familiar than I am with the intricacies of IEPs and 504 plans. But again, sometimes the therapies that these children receive, the only therapy they receive is in the school setting. And so, you know, discussion between, you know, the medical providers and the therapists is sometimes difficult when the therapists are only in school. We, as pediatricians, don't necessarily talk to them as frequently or at all compared to the therapists that work at Children's and we see all the time. And so the communication, you know, we're always, again, happy to hear communication from school staff, school nurses, school therapists about things that they feel like may not be being addressed appropriately. And then we want all of our kids to do as much physical activity as they are capable of doing. And so as much as schools can do to allow them to participate in PE that's adapted for their capabilities, we love. I mentioned briefly about mental health, and this comes into play certainly in our older kids, that body image and social aspects when you are, you know, maybe wheelchair bound or unable to participate in certain school activities due to physical disabilities becomes an issue, much more so than in the younger kids. And then again, not to, you know, end on a sad note, but children with disabilities or chronic medical conditions are at higher risk for maltreatment and neglect. And so, you know, you may be the first line in recognizing some of these signs of a child who may not be being outright abused, but may not be receiving their medications on a regular basis, or may not be, you know, in the appropriate, you know, bracing that, you know, has been prescribed for them. And so it's difficult, of course, to care for a child with CP, and it's complex and it's time consuming. And so we want to support families as best as we can. And we want, you know, again, communication is key, but also keeping an eye out for just the idea that these kids are going to be at higher risk for actual true abuse or neglect just by the fact of being special needs. And thank you.